I have a memory. No, I have a memory of Eric inviting me to Hong Kong to with other people to give a talk, and everybody had been very interactive and asked lots of questions. Then my talk came, and people fell asleep, and I said, "This is very poor." And I was taking this very personal, and then I stopped and said, out of curiosity, what is the prevalence of cannabis use in Hong Kong? 0.08. I said, oh, well. So clearly, it was not a relevant risk factor for clinicians in Hong Kong to have an hour lecture about cannabis and the role that it might play in psychosis, which is very relevant to my experience, and Adam knows. So I, with Julia and Eduardo and Diego was in the other room. So we are clinicians in Southeast London. And as David Taylor was saying this morning, if you walk in Southeast London, you don't have to ask for cannabis. You can passively inhale it. And when you look at first onset psychosis services, but also psychosis services in our trust, so the psychosis services, we have up to 47% of people with first episode that present in our trust with cannabis use. And when you look at the prevalence of cannabis use, so you look across psychosis independently of being first episode or any stage, it goes up to 60%. Now, literature has shown that we talked about medication that can have an impact on the recovery path for psychosis. Well, continuing to use cannabis independently of you taking or not your antipsychotic has a negative impact on clinical and functional outcome. People who do stay on antipsychotic would do better than the one that also don't take their meds. But certainly if you can take cannabis out of the equation or do some harm reduction, that can have a profound impact. And this is actually not my research, but there are 2 meta-analyses looking at data across the world, and there are also many longitudinal studies from the population I'm interested in as a clinician. So rather than dwelling and thinking, oh, well, nobody is doing anything about this group, this is a traditional group. I don't know in your experience, but at least where I work, this is a group that falls in between addiction and psychosis. Because services where you primarily focus on psychosis, they tend to say, going back to Adam's comments on having a therapeutic relationship to patients, well, you should stop using cannabis, not good for you. That's most of what people get. Or I can refer you to addiction. Now, a criteria for addiction in our services is that you have to be highly motivated and turn up to your appointment. I don't know about you, but if this was my criteria for my outpatient clinic, I would have lots of afternoon free. So we realized that perhaps this was a group that needed a bit more, going back to Eric's point, personalized medicine. So we had to think about delivering what has worked in addiction, because I'm not an addiction psychiatrist, but tailoring it to what works when, as well as using a substance and be dependent on it, you have an underlying active psychosis. So some of the experiences that Adam was sharing. And so I'm very fond of Walt Disney. And he used to say, hold on a sec. He used to say, am I going to be able to get this to work? No, maybe it's me not knowing what I'm doing, actually, which usually is the case. Am I pressing the right one? Yeah, exactly. So it was me not knowing what to do. Thank you. So he used to say, the way to get started is to quit talking and begin doing. All our dreams can come true if you have the courage to pursue them. So we had this idea that perhaps there was something that was needed to address particularly what was required to support these young adults with cannabis use, and psychosis to have a chance of improve the quality of life and have an impact on the recovery path. And so usually the main barrier to start is money. We usually say, oh, well, I would like to do this, but I don't have any money. But that shouldn't stop you, and I'll show you in a moment why. So we thought, well, what could be a recipe that maybe we can start thinking about to see if we can go from talking about a service for this group of young adults to actually making it real. And so I was very lucky because I work in a place where there are lots of clinicians, but also there are lots of academics. So I thought to start persecuting by email all the addiction people I knew at the Institute of Psychiatry and in the clinical setting, and also people who work in psychosis, who are my more direct peers, Of course, we had access to Robin. You know, I could ask David Taylor to come on board with his pharmacological expertise. Diego, who works in a intensive care setting, and Fiona Gugran, who works in the National Psychosis Service. So basically, you think where you work right now, take 2 seconds to think about all your friends and maybe some of the enemies in your trust that work in addiction and in psychosis. You send them an email and said, well, why don't we get together and think to develop something new, which is very good for your CV. It might get you a Clinical Excellence Award. There can be lots of outputs if you actually get it right. And then, you know, you need to summarize your idea and get some support, importantly financial, but not only support. So in my case, the main barrier was not necessarily to look for funding. I spent most of my life applying for grant, but is to get a validation for clinical staff. So there was no point for us to set up a service that the nursing staff or those who were going ultimately to refer the patient didn't believe it was needed, or didn't believe that the system we had set up was helpful, that the referral process was too complicated. So we got them on board from the very beginning, and we then got a little survey and asked them, do you think this would be helpful? And what do you think we should provide? And how do you want the referral process to be? And it's funny to say I was very lucky because the pandemic struck, because nobody sees the pandemic in that way. But in my case, of course, I had lots of time away from academic work, and I was thrown into the clinical setting. So I normally do 1.5 days of clinical work. The rest is academic work. I went back to do 5 days of clinical work. So I got to know, and Naresh is actually, you can see he had already enough of me because he's in the other workshop. Naresh was here, is one of the clinicians in, oh, Naresh, you're there. Sorry, you haven't had enough of me. I had the pleasure of meeting Naresh during the pandemic and so many of the other colleagues. And so that helped me to get their idea and input on this project. And then I had to look for funding. So you go to usually your trust management and they said, oh, we don't have enough money. NHS is always in deficit. So look somewhere else. And we were very lucky because we have a charity, which is the Mosley charity, who's usually very open to anything that you can prove as a potential immediate impact on patients' life and care. And having the support of family gives you credibility with them. I spend most of my time responding to email from relatives of my patients, but relatives of young people with cannabis and psychosis across the world, asking me, my son, my daughter has experienced psychosis in the context of cannabis use. What should I do? Is there any service? What is the best treatment? And most of my answer in the past was, I don't know, for all the answers, the questions they were raising. And so I could put together all this email and actually have them in my application and say, look, this is something that is not coming just from my academic interest, but carers are asking for something. And people who have psychosis and cannabis use, who also sometimes email me, are requesting something that suits their needs. And then involves students and trainees. Some of you are students and trainees, and you usually come for free. And you are required, I mean, I've been one of them a long time ago, you are required to do things for your training. I don't know where you work, but in our university, they're called quality improvement projects. Basically, you need to show that you have done something useful that has clinical impact and put it on your CV, and you get scored towards your exam. You can get some very motivated medical students, and so they can become with you your workforce. And Julian and Eduardo know that we have lots of clinical placement students all the time that come to the cannabis clinic. Some of them because I have an interest in cannabis. I don't inquire what the interest is about, but it is something that is very popular in our context. And then begin with certainly a simple model, something you can measure. There's no point in setting up anything if you don't have outcome measure from the start, because then if you want to make it sustainable, you need to show that people should invest in it. So, well, this was some blur that I had to present to the trust to get some support that they believe were not going to harm anybody. And the main thing was there is a clinical population that is falling into a gap, and this is a revolving door population, as we would say. Forgive me for the jargon, Adam, but it was a way to say that often, and you know because you have met many of them, the peer group, many of these young adults, and you mentioned your experience at the beginning, would become unwell with psychosis, start medication, be discharged from hospital, go back onto cannabis, relapse, go back in hospital, have an increase in meds, get better, come out, go back in cannabis, and this would be an history where you might have, and we have a couple of people in mind under our care who have been unwell because of that for 30 years with something like 19 hospital admission, most of which under compulsory, so under a section of the Mental Health Act. So we could say this is actually not just, as my primary goal, something that could benefit this clinical group, but also could save money to the trust because, of course, hospital admission are very expensive. So what we did when we went to this mostly charity, and in 2019, we got the first set of money. And the idea was that we were going to be given money to employ one full-time nurse and then one session a week, which means half a day of consultant time, and a bit of money for vouchers. The reason is that, and these were all the experts. You can see there's quite lots of experts here, and there is also Diego up there, and you have Eduardo, and you have Julia, but there's a better picture of the two of them at the end, and you'll see why I say that. So we needed to put together things that were very established in addiction because this was not a trial. And I had to say that we were starting with things that had been shown to be safe and effective, at least for addiction. And so we put together things that you would be familiar, so like motivational interviewing, SMART goal setting, and there is lots of jargon. And it's been interesting to me to realize how you use this terminology, people think you're competent. If you say supporting people to think about what they like to do with their time, which is the same thing as SMART goal setting, they think you're just amateurish and they don't take you seriously. So I learned imagery. Imagery is wonderful. First time I heard about imagery, I thought it must be something very sophisticated. And there is, of course, some psychological work behind it, but it's really about taking the time to imagine yourself visually, but also emotionally in a place where you want to be. So say the context of cannabis use, and this has caused you lots of conflict with your spouse, your girlfriend, your mom. You can imagine the day when you tell them, well, actually, today is 1 week since I had my last joint. How would the moment feel? And so, again, you don't say imagery. People might think you just don't know what you're doing. Harm reduction is something that I was reasonably familiar. I'm sure you all have experience in your clinical setting of harm reduction. Role play has been very successful. Adam, you know that one of the most common difficulties that the people we see report is to say, well, I might as well succeed in reducing my cannabis use, but then I go back to meet my friends. Most of them are using, and I find it very difficult to say no. And so we do lots of role play on in the setting where they experience how you might respond to either the social context or just the offer of saying, well, that's your bit of a joint. How do you say no? Are you ready to say no? Or perhaps you need to consolidate, your confidence in the steps you have achieved. So these are in some way very practical, common sense. Again, hot cross bun, I thought it was something to eat. I said you actually reward patients with food. But actually the hot cross bun, again, is a psychological model. And I don't know how many of you, because most of you are Anglophile, will know what a hot cross bun is. But who doesn't know what a hot cross bun is? A hot cross bun is a round brioche that has a cross on it and is usually something that you would have available or should eat during the Easter period. So it's an Easter cake, although these days you can find it in August in London. And so the idea of the hot cross bun is that you have got something divided in 4 quadrants and you talk about advantages and disadvantages of making the change that you have decided to embrace, and hot cross bun formulation, craving management. We talk about craving, and it's an important component of any substance abuse. Now, contingency management. If I had gone to the Mosley charity and said, can you give me some money for vouchers? They would have thought I was off my head to give vouchers or any proxy for financial reward to people with a dependence. Well, contingency management means that giving a financial reward. And in addiction, you would know that financial reward, either cash or vouchers, for instance, in people who are using heroin and you're trying to get them not to exchange needles or change the practice of their use, or even to attend their clinical appointment. if it is rewarded with either financial reward or a voucher, increases the chances of attendance and change in behavior. This is a population very difficult to reward. There are PET studies that suggest that the area where reward is activated in dopamine are actually discretely different from control, and also from people with psychosis without substance misuse. So these are people who have difficulty to respond positively to reward because of the changes that, well, we don't know how many of the changes are primary or secondary to the substance misuse. But the point is that you have to think very carefully how you set up the reward, because it might not be sufficient to induce change in behavior. And I don't know how this fits Argyris with how you do rewards in children, but it has to be pretty immediate. You can't say to people, I reward you in 6 months. It doesn't work that way. And so what we do is that we have borrow contingency management, but we have decided to do is that each patient has the same amount of money allocated during the, and you'll see what I mean with the therapy period, but they can choose the type of voucher they want, and they can negotiate with their therapist how the reward is spread. And usually I always say, as long as it's legal and I can provide it electronically, they can choose something that is relevant to them. So once we had a lady who wanted to do a manicure course. So I found out that I could actually get a voucher from this company. And so this was a great motivation for her, much more than me deciding to give her supermarket vouchers or, I don't know, JD Sport vouchers. A young man who would be mentioning wanted to start reading again. And so he wanted audiobook vouchers. And so the voucher actually personalized. The amount is the same for all of them within the period that they are receiving intervention and support from us. So, of course, before they start our one-to-one session, which is once a week, in theory 1 hour, but it depends where you are with your psychosis. Sometimes people can tolerate 10 minutes, sometimes 20 minutes. Sometimes what you had in mind that you would do in that session is reshaped by how distressed they are by, for instance, actively hallucinating at the time of the session. But in general, you have available 1 hour each week. That can be online or face-to-face. The online started because we were during the pandemic. We have actually kept it. Again, sometimes for these young people to go out and come to the session is very difficult because, as Adam was explaining, walking down a street might not always be a bearable experience if you are hypervigilant and if you feel under threat because most stimuli are sort of hostile to you. And so having the chance of doing your session from your own room, even with the camera off, gives you the possibility of accessing treatment from the time you want to access. And then you might move to face-to-face session if you want to later on. And this has been a very good example of how being flexible has helped the people that I'll show you the data about, the first 30 people that have come through the clinic, to actually be very consistent with attending the session, much more than they were when they were referred to addiction, or sometimes much more than people adherence to my own outpatient clinic. And so I had to say that it was important to have from the beginning some thoughts about outcome measure. And again, the outcome measure, which we call core assessment, and Julian Eduardo made it possible because Julian Eduardo had done pretty much all the first 30 core assessments for the first people who had come through and completed the intervention. Really, again, we wanted to choose not necessarily research tools because we wanted things that also were translationally immediately understandable by clinician, and also that we could have on the clinical notes that clinician could go and look and say, oh, really, the psychosis has improved, rather than things that would be relevant for us to publish paper. So something that was in between. And the core assessment is a mix of measure of cannabis dependence. So we have the QDIT, which is the measure for cannabis use disorder, which gives you a score for dependence. We have the psych-RAT, psychosis and hallucination, which are clinical measure that give you a score for delusion and hallucination. We have measure of sleep, of mood, of anxiety. We do the ACE-3 for cognition. Again, we didn't want to do psychometric tests that only trained psychologists could do. We wanted something that any clinician and even a student could be taught to do pretty easily and quickly. And also we had measure on motivation. We asked obviously about other substances. We have the audit for alcohol, and we have the Fergustron for tobacco. Giulia Eduardo, am I missing something obvious? We have the one about aggressive behavior, which have, and then we have added recently a measure of paranoia, because we're also doing a comparison with the general population. So it's the green paranoia thought scale, if you are familiar with it. The GAF, the general assessment of functioning, to see. And also we have social demographics. So we take the social demographic, a baseline, and a follow-up. And the reason why we do that, clearly gender or ethnicity is unlikely to change during the period, at least of the intervention. But what we're very keen is to translate the GAF into real functional changes. So we also want to know, have people gone back to studying? Have people gone back to work? Have people starting a vocational training? And so we repeat the main social demographic. Have people changed their socioeconomic status? Have they moved to live independently? So we repeat some of these social demographic baseline and follow up. So we have everything that is in the clinical notes. So if there is collateral there, we actually take it. We don't take direct history from collateral unless the patient, the problem is that often this group of young people is not very keen for us to have contact with the carers. But we haven't systematically done it. But for instance, some of them were accompanied by the parents, and in particular one of them. In that case, we will take collateral. But I think maybe we should do this more systematically. Yes. Yeah, the clinical team we usually have. No, this is very important. And I think actually any suggestion would be very helpful, because as you can imagine, this is a very much work in progress. And actually we have not been able to involve much the carers to this point, because we had to focus actually on the people we were looking after. And this has been something that we are beginning to do, but I'll tell you at the end. But this of even having tools like questionnaires would be something much more easy for us, not as time consuming, so we won't need more resources, but it will give us certainly more data. So unfortunately, I had to give a time, because, you know, when you especially ask for funding, you can't say people would be seen forever as long as they need. This doesn't usually go down well. I didn't know how long it would have taken. So we looked a little bit what was in the literature for addiction, what you get for general CBT in psychosis, and we thought, actually, this is an old slide. Now I put 20 weeks plus. But say in the first application, I said 20 weeks. And it's very interesting because most people would take 20 weeks. But actually, we have a couple of outliers that have gone beyond 2 years, but they're now 2 years down the line are doing spectacularly well. And this makes me think about, well, if we had stuck to the 20 weeks and said, bye, 20 weeks time is gone, they wouldn't be where they are today. So when we have a larger sample, we can actually review what is the real distribution and to try and see what predicts the outlier. And then maybe from the beginning to have more investment in resources and plan for more time if this is required. We also put them in touch with the rest of resources, so we don't work on our own. There is Marijuana Anonymous. I don't know how many of you have ever referred somebody to Marijuana Anonymous. Well, Marijuana Anonymous is pretty much everywhere in the world. It's in Canada, it's in the States, it's in UK, it's in Australia. They do a fantastic work. I had lots of preconception about them. I thought they would tell my patients to stop their antipsychotic and they would have a very sort of, well, maybe I shouldn't share my preconception. Anyway, I had a very bad, I thought that they didn't know about the possible sort of co-presence of psychosis or other mental health problem, and I was worried they wouldn't find peers there and they wouldn't feel they fitted. But then we invited a couple of people to come to what you see, what I mean with peer group. You remember, Adam, we had we had Claire that came, and then we had a guy also from the London area. And actually both of them had psychosis and cannabis use. And they were wonderful. They came to share their lived experience. And they said, well, many of us had psychosis. more or less severe. So we don't dismiss it. We understand about medication. We understand that people need to be involved in mental health services. So we do say to the people under our care, and by the way, you have available 20 for almost, well, they are free, less in UK. You have a free online option every day, 7 days a week, with no breaks over Christmas, of My You Are Anonymous online meetings and face-to-face. So this is a resource if you need top-up support, which is actually great. The UK website is wonderful. So, but if you just Google My You Are Anonymous, I'm sure you will find it and you'll be able to see. And usually they have somebody that liaise with clinicians. So you can talk to them and say, I work in this setting. You can invite them to come and talk to you and your colleagues, and you can test if they are as sensible as the people, at least I've come across. And then, of course, we have lots of activities, vocational services that we can link the people we work with. So we get the best out of what we have available. We don't want to replace anything. We just want to add something different. The core assessment is repeated alpha way and is repeated at the end. The alpha way is more to give a feedback. All the scale that by definition we have chosen give a score. So people get the score at the beginning. So we share with them, look, this is where you are with your cannabis dependence. This is where you are with your experience of hallucination and delusion, mood, motivation, whatever it is. And then they track with us over time their changes. I come from research, I like graphs. You will see an example. We build graph with a clinical student, clinical placement student. Each patient will have somebody allocated to them, a student who will build a graph with them. And the graph would have some measure from the core assessment, but also things that are relevant to them. So some will choose to have on their graph sleep, mood, money spent. They don't want to see psychosis at the beginning. And we have mood, sleep, money spent. And they track that week to week together with whatever is the goal of cannabis changes. There might be very small gram difference or changes in the amount of joints or the size of the joints or the time of the day of the joints, or depending how much availability they have, the type of cannabis that they have access to. And at the end, we repeat everything. And now we're looking at, and we are open to booster sessions, so people can come back and have follow-up session and self-refer. And we are looking now at 6 months and one year follow-up data. Any question, criticism, or advice? Yes, please. Actually, I would need Julia, Eduardo, can you help me with the, or Brian? Thank you very much. Otherwise, I will end falling down.
Hi, I just wanted to know if you used any blood or urine samples to measure the levels of cannabis?
This would be a wonderful idea, but costs money. And money is something we didn't have until now. And the other thing is that what we had at the beginning, you need two things. You need money and a lab that can do it. Most clinical settings can do THC in urine or even in saliva, but this is just a yes or no, doesn't quantify. And in some way, we felt we didn't need a yes or no THC level in urine or THC in saliva. What it would have been useful is to see changes in the level. To do that, you need a blood level. Our clinical pathology can do blood level of THC and CBD. They're no use to do that reliably. So for instance, now I'm doing it, and I'll tell you why. And I'm doing this with the drug testing unit at King's that works with athletes. So and it's actually quite expensive. It might be that where you work, and maybe in Canada also because of your different legislation, you're used to do this more routinely and they're cheaper. But clearly we couldn't do this in actually Fatima is for Canada. Sorry. Remind me where you are from? Sweden. Do you do routine THC and CBD level in blood? No, we can't do it in our hospital, or at least no reliably. The other thing is that we had a very expensive machine who I borrowed from somebody who had done research on it, which will give you a percentage of THC in urine. And so you could say the baseline was a certain percentage, and then you can track grossly changes from 1 week to the next. And it was quite interesting because some of the patients liked it, and they said it was good for me to see the change, I mean, to actually see on paper that I was progressing. And we were during the pandemic, so it was difficult to get urine sample, and then the machine broke and we abandoned it. Now I'm about to buy a new machine that can allow you to do that on saliva, so we will bring it back. It would be interesting. We have done a survey and asked them, would this be helpful? Do you think we are policing you or not? And we had almost a 50-50 feedback. When 50 said, yes, it would be nice for me, apart from the graph, to see that actually THC is getting out of my system. And some would say, well, at the end of the day, it's about me setting my goals. You know, I know if I'm achieving them or not. I don't need to there are other important things for me, like my sleep improving, my concentration improving. So what we are going to do is have it available for who thinks they can get the best out of it, on the basis of we want to do something that is as personal as possible rather than something that fits all and drive people away, because some of them might be a bit suspicious of what we're going to do with the data at the beginning of the journey, at least.
Just a follow-up question to that. Is it so feasible to measure the THC levels in urine and blood? I mean, is the relationship between intake and the levels in urine or blood, is it linear? Because I thought, as far as I remember, that cannabis has quite the high fat binding. It's very lipophile, and so very dependent on the individual. But that's because we never did it in blood tests. When I was working on a young psychosis ward as a resident, we just and we didn't measure the levels in urine either. We just did like quick tests, also because of money, of course, because they're cheap, and then just said like, okay, there was cannabis intake, yes or no.
Or no, I agree. I mean, now, so I'll tell you later what we're doing with the blood, but you have to have lots of information to take into the analysis. So it's not just about sending sample for blood tests. You would need to do the BMI. You would need to know the exact time when people last had the cannabis, and you would need to have as accurate as possible information on the amount and potentially the potency and the THC and CBD ratio. How this is possible in real clinical life, no. So now we're doing on a subgroup, because we have funding on this subgroup to also have them involved in a research project. And also, clinically speaking, to do what we have done so far, did we really need the information, given how costly they are? And we also needed to show this was feasible. And we need to show the clinical colleagues that it didn't take extra resources and burden services. And more importantly, this was done during the pandemic. So anything that had to do with biological sample was really not feasible. So now that we are doing on a subset for research, we're also going to see how feasible it is, what more information we're going to get from that. We're going to see what more better information we get from this new saliva test. If you are, actually, no, I'm sorry, I'm saying something. It's not saliva, it's a breathalyzer. Put on Google, breathalyzer test for cannabis. Is a new machine, comes from California, that has been tested and validated, which is quite interesting and potentially very, very easy, as you can imagine, to use. So and it's not too expensive, it's £1,000, so that's why I'm thinking to buy it. But I don't know how, I will need to see how useful really in reality is. Brian?
We got a message from online. So
a rude message.
Message from Simona. So Marta, Eduardo,
Ciao,
Diego,
Simona.
and Julia, congratulations for your work. And just a suggestion from you, how do you improve the motivation of the participants? And how was the percentage of dropout in your sample? Thank you.
Last bit, the percentage of?
Dropout.
Okay.
Yeah.
Well, you'll see this at the end. But the motivation, we have the Julia in the crown that you're going to see. So I have no special power, or Julia, Eduardo, or actually Adam has special power, I should say, and I'll tell you what I mean with that, in improving anybody's motivation, not even my one most of the time. So we decided to set up, which runs in parallel, actually, usually at this time, and I thought to do it live with you, but it would have been a bit complicated. This one, the peer group. And the peer group is something that we thought might help, again, during the pandemic, because Marijuana Anonymous, Cocaine Anonymous, and I can't remember which other one, Opiates Anonymous, had to all move online. They didn't say to people with dependence, sorry, too bad, there is a pandemic. You just get on in the next whatever month. They set up online support. So we thought, well, what about doing the same? And so we had already, with Julia and Eduardo, had the idea of the peer group, again, borrowing from addiction, and thinking why our patients not attending as successfully as we would like to the peer group that the addiction services are offering them, because they don't find their peers. These are people with addiction but no psychosis. So they could not share what Adam has shared with you. They will not have that component of their experience of how their life, the thoughts processing, their experience had changed within the context of cannabis use. So you remember, Adam, when we had them live at the beginning at Clapham Library. So we started renting a venue and we invited people to come. Again, reasonably daft idea out of the context, because most of them will struggle to come. The idea of being in a room with other people that not met before, if you are slightly paranoid, that's not a brilliant idea. So we were used to go there with Eduardo, buy lots of snacks, and then it was 3 of us out of perhaps of the 10 we were expecting. When we moved online, if you ever would like to join us, send me an email. We have 40 people attending. And these are all absolutely spectacular people who have any stage of psychosis. Some of them are in a PQ when they attend. So most of them would be in the community, but we have lots from acute setting, from the rehab ward, from the PQ, would be online, will listen to world experts giving a 10-minute talk on a topic on cannabis alone, cannabis and psychosis, cannabis and driving, psychosis by itself, medication. We had David Taylor coming. We had Robin coming. We had people from Canada talking about legislation. We had people from the Netherlands. We had Adam sharing his experience. So we have a mix of lived experience, like Adam coming, or other people I mentioned, and experts in the field. And then we have an open discussion. And we start in a funky way. So we always say to the speaker that they have to choose a song which they think best presents that talk. And so we start with this song. And we had amazing speakers. We had people I thought were very serious and boring who said, actually, my band, I'm going to have a video of me with my band. I don't know, Tony Argis, if you know Cyril de Souza from Yale, is one of the leading world academics in cannabis and psychosis. He had his own band with a mask because he was during the pandemic playing the sax and fantastic music. And we had all sorts of, we have also lots of raggy music and Bob Marley and you know, really, and classical music. So everybody comes with their own contribution. And we always have a brilliant discussion. And this is a setting for motivation. Adam is one of the PM mentors. So we have Adam, present Alexi, who are the main PM mentor. Adam, would you like to say what actually you do and what do we do at the peer group? Because you're much better than me at doing that.
Well, I just wanted to say that one of the main things was that since lockdown, I became a member of different groups at different universities, some from the north of England, some from the east, but which also would be weekly. But Marta's cannabis clinic, she won't be like me saying it's hers, but it's always so focused. And it is an awareness that there are like world-renowned scientists showing their studies and explaining their findings and things. Equally, there are people on wards, acute intensive wards, asking questions like, well, my friend's on, you know, he smokes weed all the time, he's a millionaire. You know, they have their beliefs, and they're encouraged to share their points of view in such a focused, positive place. And if there's very rarely do people have to be muted, but yeah, it's just an open space.
Actually, usually it's the speakers if they go on too long.
Yeah, and it has to finish by 5 because that's when people on the ward eat. So it's yeah, there's a symbiosis, I think, between everybody on the calls.
And I think sorry. Yeah, no, I just was going to say, for me as a clinician, has been an extraordinary experience, because what you had very eloquently from Adam today, we have now the benefit of hearing it every Tuesday afternoon. And it has also helped me, not just as a clinician, in the way I talk about cannabis with the people I see in my more routine, I guess, clinical job, but also how I think about cannabis research. So for me, it's been an extraordinary experience. And, you know, I always say to any students who's working with me to come along. And we have the nurses coming. So what is nice for the nurses are changing also the way they talk about cannabis. with the people they have under their care, and these have sparked lots of projects, quality improvement projects, small research projects, audit or whatever, to see actually how we can improve the care of this group. But what is nice is that when there are disagreements, so right now, and you know what I'm going to think about, we have a wonderful gentleman who, as the one I mentioned, has been unwell for many years, who would come to the peer group and say, cannabis is wonderful. And you wonder why on earth he's coming, because every week he hears most of the time that you should reduce your cannabis, that cannabis has these negative effects. And he would always have an alternative explanation, but he comes. Now, recently, so we're talking about the motivation. And there's no way I can tell him anything that he make him change his point of view. And he knows all the conspiracy theory that have been on the web in the last 2 decades about why psychiatrists say that cannabis is bad for you. A few weeks ago, he sent me a text, because he's actually doing the one-to-one with me, and said, oh, Marta, by the way, yesterday I bought a 94% THC cannabis just to see. And I said, oh, gosh. And so talking about emotion, I could have responded, are you off your head? Which wouldn't be very helpful. Or said, oh, well. So I said, well, I would think that you might notice a difference. And perhaps the first one would be your sleep. And I would wonder if you notice a change in your voices, and you will let me know yourself in a few days if things have been better or worse in these domains. And left it there. We usually speak once a week, so we were actually 4 days from the session, so we spoke, and I said, how you been? Dreadful. I haven't slept for 4 days. You know, you actually looked very bad. And I said, anything else? And then he said, well, the voices have been more intense. And do you think that perhaps there's something that's changed in the last 4 days that could explain it? And he said, well, I don't think this 94% THC helped with my sleep. He didn't mention the voices. 1 month down the line, he's saying, well, I've decided to cut down my joints from 3 to 2, and I'm trying hash because I think it's less potent, and I think I felt a bit better. This is not my advice to him. So motivation can come. I think if you give people a chance to test it for themselves, doesn't work for everybody, but this is in our model what has worked, to give them a chance to hear all the information you can throw at them, go out, test them, and in their own time, and here we're talking about somebody who's been using cannabis for 30 years, so it's not going to change just because he comes to a peer group easily, to see if by reducing gradually, he picks up any changes in his quality of life. And this is what he's seen changing. He's now starting a new job next week, which is partly online and part face-to-face. And this is the first time he's going to be in employment for 30 years. And he's making the link between what has been, and his psychiatrist has halved his antipsychotics, which again has been a big motivation for him. So RGS, you wanted to ask something?
I have 2 questions, but I'm very aware that others may want to ask questions too. But this is so fascinating and so educative. So I have maybe the first question is to both Adam and yourself. Adam, when you started your talk, you said you were planning on studying psychology back then. And what I'm interested in is whether in all the work that you do and in the way you think about these things, Adam, whether there was something before, when you were growing up, maybe we could read into the motivation for trying to understand the workings of the mind that could have been relevant to your experiences later on, and whether you take this kind of lifetime perspective in the clinic as well.
Well, I remember once terrified my mum. We were in the garden. I was about 10 years old or something, and I said, "Mum, I want to try every drug in the world." And she was like, you had to sort of palm it off, but, what a thing to say. And plus, I was convinced that the best musicians get as stoned as they can all the time. So it was basically bad information that I took too seriously.
Can I ask you? Yeah.
The answer from me is no. And the reason is that these are people that are looked after by a community mental health team and early intervention service. So they get mainstream psychological support, they get the formulation, they get the lifetime trajectory. We really focus on, okay, for whatever is the reason you want to make changes to your cannabis use, how can we help you to do that in the context of where you are right now with your psychosis? If people bring in the lifetime perspective, we work with it, but we don't necessarily ask for it. And there is a very simple reason for it. Most of the people who have been our workforce at the beginning would have not had the skills, including myself, to work with this set of information professionally. So we don't have our therapists. You might wonder, who are these therapists? So they've been clinical placement students. Sometimes I'm not, I mean, I'm a psychosis psychiatrist. I would not know what to do with developmental lifetime trajectory or life experience. This is not the work I do in my clinic. I wouldn't know how to get the best. I mean, I'm not trained for CBT except from the old days of being an SHO. Julia and Eduardo as well are sort of all-round psychiatrists. So we had to do something that was simple, that I could get most people that came my way to deliver, because these were the resources. Now, funny enough, would it make a difference if we had very skilled therapists? Sometimes we have very skilled clinical psychologists. They haven't done any better than my clinical students. I don't mean to be rude with psychologists. This is a very pragmatic approach, and it has helped for the people we see to be here and now. So why is the change relevant now? And then you want to talk, some people come with trauma, and so sometimes we time the trauma work with the psychology in the team so that you get the best out of two, but we don't get into trauma work. So it's not...
Thank you so much for that presentation. I was just wondering, given the excellent work that you do in the peer group, if that would be open to other people attending who are not part of your program. So do you allow external attenders? I'm thinking particularly of staff in remote and rural areas who maybe could learn a lot from there.
So staff, yes. I guess one of the question is, now that the peer group is part of our trust service, they had to impose some boundaries. So in terms of the patient population, is the one that is cared by the trust. In terms of staff who wants to come, and because say you email me, as long as you email me and say, I would like to set up something similar, can I come and observe? Then I have an excuse to say yes. I would say yes anyway, but I can record why I'm saying yes. The only group we have to say no are relatives, for obvious reasons. I can't have my patients and their relatives, and also the type of conversation will be very different. So we are setting up next month one for relatives. So we're going to have the same peer group for carers, which can be relatives or can be just people involved in the care of young adults with psychosis and cannabis use. And we will think with them, would they be happy to have it open? The patients, we asked them at the beginning if they were happy for staff to come, and they say yes, because they said staff don't have any idea about cannabis. They were frustrated because when they had a conversation about cannabis with the staff, both consultants, I have to say, and nurses, they were less knowledgeable than they were, and they found the conversation frustrating. The clinician had very little understanding of THC, CBD, endocannabinoid system, potency, the street names, and they said, well, why should I be credible? Why should people have very little understanding of the substance I'm using to advise me? So they were happy for the clinician to come along to be educated. And so with that permission, we have them on board, which I think is very nice. And it's nice sometimes to see the conversation between the two groups live on the peer group.
I wanted to comment on, and also thank you very, very much for this excellent presentation and the insight in your work. I was just thinking of a congress that I attended, I think 5 years ago. It was a German addiction congress in Hamburg, and there was one professor from Northumbria, I think. I just looked it up because my memory isn't that good for 5 years. It's Nick Heather. I don't know if you know him. Yeah. I think he retired now, but he said, in his opinion, and that stuck with me, that addiction is a disorder of choice. And I found that fascinating in a way, that it is that he perceived it not as a mere brain disease, and so somehow advocated a bit against the model of addiction as a brain disease, but more in a broader context, that it is a disorder of choice, because people, I mean, everybody knows the substance is a problem, at least if they're in a program, but still you take it, and it's, in his opinion, it's a voluntary decision in a moment against your otherwise voluntary choice in the long run. I don't know actually why I'm saying this now, but it just stuck with me, and maybe there's things that you can comment on it from your work, because I found that very interesting.
I'm just going to say it to you the other way. So there are lots of studies that, of course, have shown an important genetic contribution. So if you want, let's say believe there is an important genetic component, and actually Isabel will talk about that, is not as high as you might think. And there is, forgive me for saying this, Adam, a brain disease, whatever that means. The choice should also work the other way around. If people want to make a choice to change the amount of substance they use, or even have a break and see if this gives them, other options in terms of their well-being, why not to do that? So we're not necessarily telling people what to do, and we're not determining the course of their life from that point onwards, but we just do with them a journey that might not represent a permanent change. So there might be that, and people that work in addiction will tell you that Adam in some way probably is more the exception of having abstained for 13 years. Most people are likely to relapse within a year. But hopefully if they have learned that there is a chance that if they make the change again, they are less likely to go back to hospital, that might be rewarding enough or motivating enough to battle with the drive towards whatever is the substance. I feel very strongly about that. I don't take any drug, but I don't know if it's an addiction, but my drive is food. And over my lifetime, I had to battle with the balance of enjoying food and my health, and I guess weight as a measure of it. And there are times in my life where I have failed, and you might say, well, I'm doomed to be slightly on the overweight range, because for me, food is an extraordinary pleasure. But equally, I know that if I manage to reach a certain level of control, I can get both. And so when I put myself, and I often give the example of chocolate, and people pick on me, now they know, and they show me a picture of chocolate and ask me where I am on my chocolate control craving. But this has been very relevant to me, because sometimes I bring it back to my everyday relationship with, it's not just chocolate, unfortunately, it's much more than that, is that people should be given a choice to make changes, even if genetically, biologically, they're driven towards lifestyle choices that can have a negative impact. And by all means, not all cannabis users, or not all people with cannabis use dependence develop psychosis. They want to continue to use cannabis, it's up to them. But for this group to have a chance of seeing what happens when you make a change, I think it's what I'm very passionate about. Wow, oh dear. Well, it's up to you. Okay, you can go with proximity.
I was wondering, I heard several times for other addictions that people are self-medicating. For instance, alcoholism are self-medicating social anxiety or depression, or even cocaine, they're self-medicating ADHD. I was wondering if there might be something similar to cannabis use.
Well, you are leading about now the world-leading expert on the reason why this population uses cannabis, because his paper has just come out. Eduardo, would you like to say what is actually the proportion? We didn't agree. What is actually the proportion out of people with psychosis in your study? That
well, yes, I would first say that when talking about self-medication, we should divide and consider that not self-medication does not necessarily imply reverse causality. So there, even if some people might use cannabis to self-medicate, it's not necessary. This does not necessarily indicate that they are self-medicating from psychotic symptoms or pre-psychotic symptoms. And what we actually did was to look at reasons why people use cannabis.
In the first place.
Why people start using cannabis. And we saw that people with psychosis, both people with psychosis and healthy controls, are much more likely to start using cannabis because of their friends, so in the social context, although cases are more likely to start using cannabis to feel better.
But what is the percentage, Eduardo, of these feeling better? Okay.
It is a minority, so it is roughly approximately 5% for controls and about 15-20% for cases. So this is a minority, and also our to feel better was quite a broad category, as it pictured all possible to feel better motivations. So to feel better from either a physical or psychological discomfort.
And I guess your point is very important, and with Adam we see this all the time. I mean, you had the reason why Adam started using cannabis, and this is the majority of the people we see. The one that had developed psychosis, they will say that they continue to use cannabis because it helps with their sleep. So in that context, you can say that it helps with their anxiety. And so when we work with them, we look at alternatives to achieve the sleep, the anxiety relief, the social confidence that they are struggling with, rather than cannabis. Because you're absolutely right, when people choose a substance, and these people are choosing preferentially cannabis, is because there is a specific effect of the substance, and this is what we look at together. And then I'm going to show you that actually we're doing something good, rather than I'm going to show you at the end. No, you can ask your question. I want to move forward.
Can I go
Oliver,
ahead?
yeah, no, you can go ahead.
So first question, is that a cannabis plant at the front there? But my main question is, what was your biggest mistake in setting up the clinic? And what would you do differently?
So I think what I would do differently is that I would set up the peer group online from the start, because there was a lots of waste of time and resources at the beginning with the face to face. And then I guess the biggest mistake was not to Julia, Eduardo, can you think about what was the biggest mistake? Any data that we should have collected and we have, I mean, to collaborate with Professor Oliver House and get some neuroimaging. No, I'm not saying this, Oliver, I'm not saying this because you're here. We had a chat about this. I think this is a great opportunity, and the people who come to the cannabis clinic are very keen in being part of research. They've been contributing to research across the trust. And so perhaps having sort of a more biological understanding of what is different about this group compared to other group that, Oliver, you have expertise on, I think would have been very valuable. And for these 30 people to also have some biological tracking of before and after they made a change that we only been able to measure with, as you can see, questionnaire, I think would have been very, very helpful. Julia, Eduardo, can you think about, or Alex, you've been to some of the peer group, anything that you thought we should have done differently? Or Adam, anything that you think we've made mistake, we should have done differently?
One thing that I thought was really effective was signposting to charities and organisations in the local area. Like that would be something you can go to during the day in the week, like boxing or, music, vocational stuff.
Like the one we did recently.
Not just to Marijuana Anonymous, but also things that they can actually do and like work towards certificates in.
And this is something that we thought about a bit late in the day, I mean more recently rather than at the beginning. Julia, Eduardo, can you think about? Yeah. So Julia is saying, yeah. So one of the things we were not able to provide at the beginning was the continuity of care, or not always actually, the continuity of care that Adam was talking about, because of course clinical placement students stay with you for 2 months. We didn't have an alternative at the beginning. I just needed something that allowed me to get some data to go back to the trust and have more money to get permanent staff. And now we have permanent staff, which is what allowed me to not to be at the peer group today without feeling too guilty about it. I will think about it. Can you think about any mistakes, Julia? Yeah. And the other thing about the students, they are often closer in terms of age to our clinical population. And I think the interaction is much more helpful than the one with me, for instance, or even already with Julia and Eduardo, still very young, but older than some of the first episode. We didn't bring digital technology in from the beginning. Again, we didn't have resource. Digital technology with this group works very well because they are very familiar with video games. They are familiar with going on the web. That's often where they get their resources and their information, even the one that goes against what they might be learning. And then it's something that we are actually applying to be able to develop a digital device to work alongside everything else that we're doing. But Oliver, anything that you spotted, because you have developed a fantastic service, so you know what works and what doesn't. Is there anything that sounded daft?
No, I can't think of anything.
I mean, things will pop up. I mean, larger is the group of people we're going to collect data on, things that we could have done better. And we're doing qualitative analysis as well. So for these people, I don't have time to show, we have qualitative data where the team, the referring people were all sort of interviewed. It was actually the project of one of my students. I just want to show you, just for sake of, have I wasted your time? I hope not. But so this is on the first 30 people who have completed treatment. So here you have the famous QDIT, which is the cannabis use disorder score. You are above 8, you are dependent. You can see that on average, all the 30 at baseline were above. A follow-up, they're all below the red line. Why they're all 0? Well, because 24 out of the 30, 80% achieved full abstinence, and the 6 who reduced went from every day to once a week, and they represent this orange, which is not 0. As you can see, there was a bit of nicotine dependence, nicotine use, which doesn't reach threshold for dependence, which was driven by the fact that they were using cannabis with tobacco. So we work very closely with the tobacco cessation service, and this is a different story altogether. You can ask me a question about. There was a little bit of alcohol use, and as an accidental effect, we had also reduction, but these were not people that met threshold for alcohol dependence. So this is baseline money spent. As you can see, these are people who are financially inactive. So almost £80 a week is a lot of money out of benefits or parents' pockets. And they go down to 20. This is the people that, as you can see, 6 that continue to use once a week. And here you have frequency of use. As I said, it was 100% every day and has gone down to once a week. So this is a simple, a simple regression that shows how this is the GAF, General Assessment of Functioning, goes up when the QDIT score goes down. So when you have a reduction in cannabis use, you have an improvement. Is it clinical relevant? There was actually another, I don't know why I'm showing this graph. They actually show you in bar chart how, there are the ice cream. They can start bringing the ice cream in here. Yeah, you can bring them in here while I finish with this slide. Thank you. Would never keep you away from ice cream. And you can see there is an improvement when you look at the 2 components of the GAF, both in symptoms and functioning, which is actually clinically relevant. And how is this mean clinically relevant? So here's a different way to show the GAF. So at baseline, the 24 who achieved full abstinence were all socially inactive. And at baseline, only 2 of them remained socially inactive. All of them have gone back to vocational training, education. 12 of them have gone back to to pay employment. The psychotic symptoms, so here we have the psych, rat, hallucination, and delusion. We haven't talked about the symptomatology, we don't have time. But it doesn't surprise to me that the reduction in hallucination is not striking, although there is one, but it is remarkable for delusion. And this is actually significantly very, very relevant, clinically very relevant, sorry. And so anyway, I hope I've shown you that in a very non-sophisticated way, we are collecting data that was showing that these changes are achieved. And don't get distracted by the ice cream, it's not cannabis. These are actually maintained 6 months in 20 out of the 24 who have achieved full abstinence. The other have not reached yet the 6 months. And out of the one who have achieved 1 year, 70% of them have been discharged to the GP. So these are people who are not longer in secondary care. And this is a nice, actually Adam was interviewed, you can see Adam Gridley was interviewed, but this is a quote for one of the patients who is saying, with the clinic, I'm looking at life in a whole different way. My brain is starting to work again. I'm doing an apprenticeship. It's changed my life. So say this person in a year time goes back to cannabis. He knows that when he's off, he can do an apprenticeship. And I think that for me is something that can potentially have a long-term learning effect in, is it worthwhile to make a change about cannabis use? And this is a vignette that we have developed with actually our patients. So this is the journey that they want to do. They want to go, they don't necessarily talk about psychosis. They want to go from a brain full of cannabis where there is little space for exercise, music, reading, to a brain where you can do all of this again. Some of them ask me if I can promise a girlfriend or a boyfriend. I can't do that. But for a couple of them, it has worked, but nothing to do with the clinic. And this is the team. You can see Julie and Eduardo making their own hashish. And it has an effect, placebo effect. They're both quite cheery. Robin has a big bowl of cannabis and Diego in the cannabis plantation. These are my pets who are usually part of the peer group, because if you come to the peer group, you see me with one of them at the background. So this is by all means a teamwork, which couldn't happen without Adam, and it wouldn't have happened without Julie and Eduardo doing all the core assessment when it was only the 3 of us. And it's very much a work in progress. So if after this you have any comment, criticism, something that you think it would be great that we are not measuring, any emotional scale that could be helpful for the work, please email me, because we have now actually money from the trust to make this a permanent service, and we have more resources to scale it up. So this is a time for good changes. Sorry, I've given up on the microphone. And now, this is another potential source of addiction, but as you heard, no psychotogenic. So please enjoy. So I know from the catering that some of you have enjoyed the food too much to a point that there was no left. I didn't have any lunch because you ate it all. So these are counted to be maximum 2 each, please. So don't have 5. And enjoy it.